Everyone, we're going to get started. Today I have the pleasure of introducing our grand round speaker, Dr. Reynold Panettieri. Dr. Panettieri is Professor of Medicine and Vice Chancellor and Director of the Institute for Translational Medicine and Science at Rutgers University. He is the recipient of numerous awards, including the Robert E. Cook Memorial Lectureship at the American Academy of Allergy, Asthma, and Immunology, the Joseph R. Roda Award for Scientific Distinction, and the Recognition Award for Scientific Accomplishments from the American Thoracic Society. Dr. Panettieri has served as principal investigator on several NIH-sponsored grants and industry-sponsored clinical studies. These include examining novel approaches to modulating G protein receptor function and New Jersey's only CTSA hub titled New Jersey Alliance for Clinical Translational Science. He is the author of over 525 peer-reviewed publications with a clinical focus on managing the comprehensive care of patients with asthma and is engaged in clinical investigation focused on the management of asthma and COPD. Please join me in giving Dr. Panettieri a warm welcome.
Wow, that was a wonderful introduction. Thank you so much. Really appreciate the hospitality that Sinai showed last evening. Great number of people came out and friends. It's just a joy to be here. So today we're going to talk about precision approaches in the management of airway hyperresponsiveness and inflammation. Now, does anyone in there see the word asthma? No. Wow, what's going on? Well, you know, if we think about our paradigms of asthma and COPD, they sort of collided. And I think what happened is we had sold a bill of goods with a topic, but really, as physicians, we should look at phenotypes. And when we think about the phenotype of airflow obstruction with and without reversibility, with and without cigarette smoke, I didn't use asthma or COPD, but it allows us to understand the pathogenesis of the disease. These are my disclosures. None of these will have impact on this talk. The objectives is we're going to talk briefly about biologics in asthma within that context that I just raised. And then we're going to embark on a new paradigm of airway hyperresponsiveness. Not only are pathways that induce or amplify contractile agonist shortening of airway smooth muscle, but the loss of beta agonist responsibility gives an integrated signal of airway hyperresponsiveness. So stay tuned with that. Talk about a little bit of cell signaling. So if you need to go get coffee, please get it now so you stay awake. And we'll talk about targets that can improve relaxation and a new biomarker that we're really, really excited about. So let's talk about the burden of asthma. How many people in the United States have asthma? Well, it's really common, right? About 1 in 20 of the US population, that's about 25 million. You can see the breakout in adults and children. And you know, the sad thing is that since 1970, we have not changed emergency room visits or hospitalizations for asthma. Since 1970. That's over 50 years. And think of what happened. We've developed 6 biologics. We have the best ICS LABAs that you can have and a variety of other therapies. And yet, ER visits and hospitalizations haven't changed. Now, if we look on the right side, you can see that in this study, it doesn't look like we're doing so badly. About 70% of patients have well-controlled asthma. This was a primary care database that came to this conclusion. However, if you really do a deep dive and use objective measures of control of disease, what we find is about 70% of patients have uncontrolled asthma. That's miserable. We're not doing a good job. And what about the physician's perception of control and the patient's perception of control is uncoupled. You ask physicians, does the patient have controlled disease? They'll say yes. You ask the patient, they'll say yes. Then you do objective measures like the asthma control test or FEV1, and what you find is that they're both wrong. Matter of fact, in the GINA guidelines, and this was a survey of about 775 patients, uncontrolled, partly controlled, and there's the definition, the ones that you're very familiar with, right? Nocturnal awakenings, use of rescue therapy, sleeplessness, And then well-controlled well, you can see, we have about 70% of patients who are uncontrolled. If we ask the right questions, you actually get the right answers. Now, well, what about if we use the GINA guidelines and we push therapy forward and go to high-intensity treatment, that is the high-dose ICS LABA, what one can find as you progress through steps in the GINA guidelines, the number of not controlled asthma goes up as we increase medications. Now, why do we increase medications? To control the disease. But what we find is we find a group, a cohort of patients that are insensitive or unresponsive, and we keep giving more medicine, more medicine, more medicine. We're not solving the problem. Matter of fact, what do? We induce OCS or oral corticosteroid burden, both inhaled steroids or oral steroids. So one of the struggles we have, unlike other diseases, asthma is viewed as an acute illness. I get sick and I get better. So patients view exacerbations as not that concerning. Yeah, it's a nuisance. And yeah, I got to take a handful of prednisone for a week or two, but it goes away. But up to 60% of patients, 60% have moderate to severe asthma, have long-term oral corticosteroid exposure and burden, inducing glaucoma, cataracts, obesity, depression, diabetes, hypertension, cardiovascular disease. So what we need is probably engagement of specialists who take care of severe airflow obstruction a little earlier. And about 77% of patients, PCPs, refer patients with asthma to a specialist, but usually after the horse has left the barn, after multiple exacerbations and other complications. So, missed opportunities. Incomplete control of symptoms and inconsistent efficacy really drives the morbidity that I showed you earlier. Now, mortality in asthma is uncommon, right? Last year, about 3,500 patients died of asthma. Matter of fact, if I was a public health doctor and wanted to save lives, I'd eliminate steps, because last year, 28,000 patients died of falling down steps. I could save more lives than that of asthma. But remember what I said, ER visits and hospitalizations are still miserable, and we haven't impacted there. Now, what we do have is the idea of type 2 or T2 inflammation. I'm going to develop that in a bit. But many patients switch therapy because of failed treatment, and biologics reduce exacerbations only by about 50%. Every phase 3 trial of a biologic has effectively decreased exacerbations by 50%. That's the glass half full, right? The other half of that is 50% are insensitive. Matter of fact, I get often, if my patients only took their inhaled corticosteroid and LABA routinely, I could make asthma go away. Guess what? Doesn't work. That's why patients don't take it. It's not because they're non-adherent. They have found that I don't get better when I take standard of care inhaled corticosteroids and LABAs all the time. So we have a disconnect between expectations of the patient and what we prescribe. So what are the current guidelines? This is the circle of life, right? I could put this up in an economics class. I could do it in a history class. It's assess, adjust, and review. Assess, adjust, and review. What does that mean? When you're faced with an asthmatic in front of you, think about it. If the patient's controlled, can I decrease their dose? Can I assess their FEV1 and their asthma control test? Can I adjust the therapy to decrease exposure to oral corticosteroids? And then after I make that adjustment, see the patient back and review the outcomes. Now, on the review, it's symptoms. I like the asthma control test. There's a number of other tests that are available. We also do lung function at every visit, and we do FeNO. I'm a big FeNO fan because it gives me objective measures to correlate the patient's symptoms with outcomes I could track. And that becomes easy for me because I'm going to use those as I assess and adjust therapy according to those objective measures. So how do I do T2 inflammation assessment? All right, need to take a moment here. There's three cytokines that are important. Three cytokines that are important in T2 inflammation, right? There's IL-13, there's IL-4, and there's IL-5. IL-5 is required for trafficking of eosinophils and eosinophil survival. IL-13 and 4 are the biggest cytokines inducing mucus gland hypertrophy, hyperplasia. So those are the three cytokines that you need. Now there's another group of cytokines above that called the alarmins. The alarmins are secreted by epithelium that gets injured. So think of the epithelium not simply as a barrier function, think of it as an immune organ that actually can sense injury and respond by secreting alarmins that then activate the IL-5 pathway, the IL-4, and IL-13 pathways. 13 and 4 activate cells by a common receptor, the IL-4 alpha receptor. When that gets activated, it drives downstream effector cell function. Now, blood EOs are critical. I look for a blood EO count of 150. We're talking about T2. 150, a pheno of greater than 20. And then if the patient's atopic, now total IgE is not helpful. Total IgE does not tell you if you're atopic. You can get high IgE levels and still have specific IgE that's 0. So the best way for pulmonologists to do this is to do a specific RAS or a RAS test, or if we're allergists in the audience, you're going to do skin prick tests. If T2 inflammation is present, then this is going to respond to inhaled corticosteroids as long as people are adhering. The pheno goes down, and typically the patients could improve. Now, the mediators I just talked about, this is functional redundancy. If you don't hear it in my talk 5 times, it's not important, okay? IL-4, IL-13, and IL-5 are the critical T2 inflammatory mediators. What drives those are the alarmins. The alarmins are IL-33, IL-25, and TSLP. Do I need to know all those? No, not today, because we only have one anti-TSLP monoclonal, so don't worry about the others yet. But in a couple years, we'll have an anti-IL-33. But those are upstream from the other ones, and they can elevate the eosinophils. So the eosinophils greater than 150, skin prick test and specific RAS or 20 pheno gives you T2 inflammation. This is the current guidelines. These are the GINA guidelines. I really do enjoy the GINA guidelines. They're crisp and they change every year and they stay up to date. Steps 1 and 2, low dose ICS for Motorol. And then as you progress, you get greater therapy. When you get to step 4 and 5, we start thinking about biologics. There are several exits here that can be utilized to control the disease. The other notion is not only the GINA guidelines, but also the NEPP guidelines have recently said that we should not be using albuterol rescue alone. That should be coupled with ICS. And SABA in the United States, we don't have smart therapy. We're unsmart in the US, but we can use ICS albuterol. And I'm gonna give you a rationale for that in the end of my talk. So engage specialists. We're not evil. We're friendly people. We send patients back and we smile. What we can do is not that we're smarter. It's simply we have access to pre-authorization for biologics. And the biologics are very complicated. So if there's a doubt, get the patient into a specialist who could help manage your patient with uncontrolled asthma. And it also facilitates some of the objective measures that we have talked about. What about biologics? Well, this is a really important point that we all think about. Well, you know, Panettieri, shouldn't I just bump up my ICS LABA dose? Well, yeah, that was done. And what you can see here is the value of stepping up from medium dose ICS LABA to high dose. Is that a successful approach? Well, if you look here, patients stepped up from medium to high dose. Patients remaining stable, looks about the same. How about improved? Same. How about worsen, same. So bumping the dose of ICS-LABA didn't really help control patients any better than the lower dose. Now, what do? I tend to start everybody on high dose. Why? Well, I showed you there is no dose dependence with steroids in controlling inflammation, but what I can do is if the patient is an ICS-LABA responder and they do really well, guess what I'm going to do in 3 months? I'm going to say, you're doing so well, I'm going to decrease half the dose of ICS you're on. Man, you should see the patient's eyes light up. They're thrilled. I'm doing better. I'm on half the dose of medicine. That's much better than taking a drug that isn't working and doubling the dose and saying, I hope this works. That won't work, all right? So start high and go down, and you'll get better adherence. So who gets biologics? That's shown here. Well, about 25% of patients today with asthma could actually qualify if they're on high-dose ICS-LABA. About 17% have difficult to treat asthma, and about 3.7. But all of these circles, concentric and within each other, are patients who are biologic therapy possible. So there's 6 biologics. Omalizumab is an anti-IgE. We've had it for over 23 years. Mepolizumab, resolizumab, benralizumab are all anti-IL-5s. Now, they're not all the same. 2 of those bind to the circulating ligand, preventing the IL-5 receptor activated. So they don't eliminate eosinophils completely. However, benralizumab, because it has antibody-directed cell-mediated cytotoxicity, say that early in the morning, it will find every eosinophil in the body and kill it using natural killer cells in the body. It is a very cool mechanism. 1 dose will take out every eosinophil, not only in the patient, but on the block for which he lives. It's really effective. Now, why is that important, Panettieri? Well, I'll tell you what. I'm all about a yes-no answer. All right, you're going to hear a term, pharmacodynamic biomarker. Pharmacodynamic biomarker. On round, say that to the attending. People will look at you like you know what you're saying. In any case, what it does, it means I engage a target and I eliminate the eosinophil. Doesn't tell me if the patient got better, but I know the drug worked. So after the first dose, I see the patient a month later, their blood eosinophil count that was 600 is 0. I know the target's engaged. Then I ask the question, is the patient better? Yes, no. If the patient's not better, the FEV1 didn't improve, symptoms didn't improve, they can't taper their oral corticosteroids, they're a unresponsive IL-5 antagonist, I kill the drug and move on to the next one. I did that in 30 days. I'm all about killing drugs quickly. And I tell the patient that. So the anti-IL-4 alpha receptors, dupilumab, we only have 1 of those, and TSLP is the anti-alarmin. So what you do need to know is that each and every one of these in their phase 3 studies decreased exacerbations, improved quality of life, for the most part improved the FEV1 except for omalizumab, and most have studied and shown that they can decrease oral corticosteroid burden. So how do I choose these? I choose them by biomarkers. High eosinophils, perfect target for anti-IL-5. High FeNO, perfect target for dupilumab. If I use dupilumab, FeNO goes down to near 0. So I know pharmacodynamic biomarker, I acted the drug, activated the pathway, and then I can answer the question. Also for IgE, omalizumab is very effective, but also interestingly, TSLP can drop total IgE levels as well as dupilumab. And some of these drugs have other indications. So this can't be read easily. What it tells me is I move back and forth through this process with a best guess in my first biologic. What is my best guess that this prominent biomarker can be affected? Put the patient on the drug, and how long? For about 30 to 60 days. At that point, I'm going to make a decision. I kill the drug or move on. Now, if the patient also has comorbidities, like atopic dermatitis, chronic rhinosinusitis with nasal polyps, effectively chronic idiopathic urticaria, EGPA, eosinophilic esophagitis. There are drugs that are indicated, so you get a 2-for-1 sale rather than using 2 biologics. So a biologic is probably sort of a low-end Toyota. If you start to use 2 biologics, now you cross into a Lexus, and they get very costly. So rather than picking 2 biologics, try to pick one that is going to cross over to multiple comorbidities. Engaging the patient is really important. When I start a biologic, I tell the patient, this is my plan. Do you want to get injections in the office? Do you want them at home? Do you want it by pen? Do you want it by this, that? Do you want it every 2 weeks? Do you want it every month? Do you want it every other month? So we put together a plan. We discuss when we're going to make a decision as to change the plan, so there's complete expectancy from the patient. Be transparent and engage the patient. All right, we're going to change gears here and talk about a new paradigm. And this new paradigm is a conceptual framework, and think of it this way. Airway smooth muscle is the pivotal cell regulating bronchomotor tone. I can make that cell hyper-responsive to everything, non-specific airway hyper-responsiveness to histamine, methylcholine, allergen, cat dander, emotions. That contractile pathway can then modulate airway hyper-responsiveness. But what if the counteractive pathway of relaxation is impeded? Now I have unbridled smooth muscle contraction, and the manifestation, the attribute, the phenotype of that is what? Airway hyperresponsiveness. Not that I amplified the contractile side, I simply diminished the ability to relax. And that is a new conceptual framework. So muscle has a lot of job descriptions. We're only going to talk about one today, and that's excitation contraction coupling and how this works. Well, we're able to study UN airway smooth muscle and culture. We have hundreds of these that we've collected over the last many decades. And what we can do is these are all primary cell lines from asthma and non-asthma patients. All the asthma or fatal asthma that had died. We harvest the cells, we grow them, we can passage them up to about 4th times. And we can study actually single cell contraction. And that's what's shown here. We put a magnetic bead on a cell. We then torque that cell under stimulation, and we can determine the shortening capacity of a single cell. And here, what we did is we call this cell stiffening because the cell stuck to the plate. So it doesn't shorten because it's stuck, but it does tense up. And we can measure that in individual cells. Each of these dots are an individual cell. The end's about 300 cells. If we gave the cells exposure to IL-13, look what happens. The methylcholine or carbachol that we give here, a contractile agonist, causes increased tension. But if I give IL-13, I get more baseline stiffness, and I get a bigger signal to methylcholine. So I generate airway hyperresponsiveness. So what we then did is we took 50 fatal asthma and 50 non-asthma patients, grew their airway smooth muscle, and asked the question, what mechanicophenotype do these cells have outside of the body removed for years? And what you can see here on the asthma side versus the non-asthma side is there is much greater contractility in asthma-derived airway smooth muscle intrinsically. And that's demonstrated down here when you look at early or late passage. It looks like the airway smooth muscle derived from asthma are intrinsically hyper-responsive. They're twitchy, and they're more twitchy than sex and race and ethnic matched. If we look at cell stiffness now in response to histamine or methylcholine, non-asthma here, you can see these are much bigger signals. And you can also see the dramatic difference in the asthma versus non-asthma. So this is a really exciting data suggesting there is an inherent airway hyperresponsiveness, hyperresponsivity to contractile agonists. Well, that's nice. Panettieri, those are single cells. Is it real? Is it just some kind of artifact of you culturing these cells? So what we then do is we take whole lungs from humans. These are aborted lung transplants, can't be transplanted. They die from catastrophic brain and heart injury. We get them in the lab about every 2 weeks. We inflate them with low melting point agar. We cut them with basically a big butcher knife. You get a beautiful piece of ahi tuna. And then what we do is we core them, because now they're infiltrated with low melting point agar, and this is on ice. We core them, and then we slice them on a vibratome, and we make little discs of lung. And these little discs of lung, there's a small airways tethered open at FRC, and we can make these contract and relax. The cilia beat, they secrete mucus, little mucus balls spin in the middle. It's really interesting. And we can keep them alive for 2 weeks. And we can get 700 slices from one lung. We do about 20 lungs a year. So it gives you an idea of the robustness. And here, this is what we measure, carbachol here, contractile agonist. That's up here. We increase our dose of carbachol. We get beautiful luminal diameter narrowing. And then we bronchodilate with isoproterenol, not only isoproterenol, but albuterol, formoterol, whatever your favorite beta agonist is. And we could dilate. So we constrict, we can dilate. So now we have a model with all the cells in register. The epithelium's there, the muscle's there. What we don't have are trafficking leukocytes, right? There's no circulation. So if we then, remember I showed you those individual cells stimulated by IL-13? What if we gave IL-13 here? What we get is a shift in the curve to the left and upward. So an overnight incubation of IL-13 in a non-asthmatic makes the luminal diameter narrow more robustly to carbachol. What about IL-33? Now, IL-33 is an alarmin. This is secreted by the epithelium, and look what happens here in a dose-dependent manner. The curve shifts to the left and upward. Here you can see the EC50. Lower means more sensitivity, and you can see in a dose-dependent manner we get hypersensitivity to carbachol when we give IL-33 or IL-13. Now, not only that, but even TGF-beta. Now, you're thinking TGF-beta, that is a big player for fibrosis and airway remodeling and all that. Well, what if I take TGF-beta and give it overnight? I'm not getting any growth of cells and no matrix deposition, but what I can make is the airways more responsive at the EC25 here, and that means that TGF-beta primes the muscle to be hyper-responsive. Why would that be necessary? Think about a wound. Our body's really smart sometimes, but if you cut your hand and you have a wound, TGF-beta goes up enormously. How does that wound close? Well, by second intention. But that second intention is actually shortening of fibroblasts. And that shortening of the fibroblasts can help a wound close in your hand. Now, when you get an injury in the lung, that same injury repair response occurs. TGF-beta is liberated. It's trying to close a wound. In this case, that's a problem because what you get is airway hyperresponsiveness. So we can see that cell stiffness in response to TGF-beta goes up in a dose-dependent manner. If I use a blocker of the TGF-beta receptor, I can decrease that stiffness. And we can see that with methacholine, you get an enhancement of the signal. And in part, that is inhibited by the pharmacologic inhibitor. In the case of histamine, you see the same thing. TGF-beta makes the muscle hyper-responsive to histamine. And if I block TGF-beta, it goes back. So this is a general phenomenon. But does it increase calcium? And what was interesting is the mechanism by which TGF-beta primes has little effect on calcium. And this pathway IP3-mediated calcium release causes contraction, but there's another pathway that actually amplifies that. And in our hands, this pathway is very important. So TGF-beta, through activations of SMAD, can actually affect this alternative pathway that decreases the phosphatase and enhances contraction in this pathway. So let's talk about relaxation. Now, I showed you this pathway. This is contraction. This is the calcium pathway, but you know, it doesn't enhance calcium. It seemingly things modulate this pathway. How do beta agonists work? They're great. Everyone in this room is prescribed albuterol, right? Well, how does albuterol relax airway smooth muscle? Well, it does it by, boom, working at multiple areas. That's just the kind of drug you want, right? Not just one spot, but all over. The problem is if you use too much albuterol, what happens? You desensitize the beta receptor and you lose function. So it's not the best thing next to sliced bread when it comes to bronchodilators. So why are we using it? Well, we don't have an alternative, so we use it. So bronchodilators are the cornerstone in the management. It's a $42 billion industry in bronchodilators. That's a big number. And current bronchodilators have problems. You can desensitize the beta receptor. I'm going to show you what happens with IL-13 and IL-4 in a minute in viral infection. And we have not had a new drug in this space for over 40 years. That's shocking. Tachyphylaxis limits efficacy. T2 inflammatory agents and mediators decrease responsiveness. So do alarmins and so do RV, supernatants. So beta agonist hypo-responsiveness. Remember I showed you asthma contracted more than non-asthma cells? Well, the problem is they also don't relax as well. So even though they're hyper-responsive, they have an intrinsic defect in their ability to bronchodilate or relax. So if I take albuterol and take those lung slices and expose albuterol for 3, 6, and 12 hours to our slices, look what happens when I come in with a beta agonist like isoproterenol. Well, as I increase the time for which I expose the slices to albuterol, I decrease the efficacy to the point of 12 hours of albuterol exposure to a slice makes the muscle 50% capable of relaxing. That is classic tachyphylaxis, and that's shown over here. So how do I fix that problem when I give albuterol? Well, what we notice is when you give steroids at the same time, what we can do is prevent desensitization of the beta receptor. That's really important because when we give unprotected albuterol, pardon the term, to patients, we expose them to the capability of tachyphylaxis. But if I take a drug like budesonide albuterol together, I can never tachyphylax to a beta receptor agonist. Matter of fact, that dotted line shows you dexamethasone by itself, which is one of the steroids we use, actually enhances the responsiveness to beta agonists. We'll come back to that. Just some pharmacology here. Control albuterol. You decrease the responsiveness, but with dex or fluticasone, I can reverse that. And that's shown here, looking just like the others. Now, if I skip the beta receptor and go to forskolin, look at that. That doesn't happen at all. Forskolin activates adenyl cyclase downstream from the beta receptor. So this is purely a beta receptor phenomenon. Now, some in the audience can remember 30 years ago, people showed if I give steroids, I get more beta-2 adrenergic receptors on the cell surface. So we did that experiment. Here, we desensitized albuterol, marked decrease in the number of receptors. But look what happens when I gave dex. Dex reversed that. It didn't put more receptors on the cell surface. The cell receptors are more functional in the presence of steroids than not. So what happens with cytokines? If I give IL-13, rut-row, 50% relaxation. IL-13 impedes beta agonist hyporesponsiveness. IL-33, an alarmin, same story, markedly diminishes the capability of bronchodilation. Now, RV, if I infect epithelium, take the supernatants from that and put it on our lung slices, it loses its ability to relax to beta agonists. So rhinovirus, one of the largest causes for exacerbations, can actually induce hyporesponsiveness to beta agonists. Now think about that. If my patient is not responding, and what are they going to do? Use more. And if I use more and I don't have steroids on board, guess what's going to happen? I desensitize the beta receptor and they get in extremis. TGF-beta also has the same phenomenon. So there's a story here. Things that cause hyperresponsiveness to contractile agonists actually impede the ability to relax. TGF-beta impedes the ability to relax. And that is shown here also when we look at phosphorylation of light chain. Now, we showed that that not only occurs with beta agonists, but with PG2 also. And the way this works is very cool. In the instance of TGF-beta increases phosphodiesterases, and it increased the PDE4. And as a consequence of that, the PDE4 breaks down cyclic AMP. So in this case with TGF-beta, one size doesn't fit all because the cytokines don't induce phosphodiesterase expression, but in this case it does. So we've tried to devise new beta agonists, so new bronchodilators. So what we do is we take our airway smooth muscle, we plate it on a 180 well plate, and we monitor the Maltese cross. So now what we're doing in real time is giving a contractile agonist, one cell across this, and it makes the cross occur. We then give a bronchodilator. In this case, it's a PI3 kinase inhibitor, and it's as effective as formoterol in relaxing the muscle. But what's more exciting to us is this drug works in the face of desensitization of the beta receptor. So here we desensitize the beta receptor. I showed you that it doesn't work anymore. But in this case, when I use a compound that attacks PI3K as an inhibitor, it is equally effective bronchodilator. We then looked at it in lung slices, and we can show it's just as effective as formoterol. And if we go down that pathway, even one step lower to Rho kinase, we can make a better bronchodilator. So now we have three targets that we're developing as new bronchodilators that are not susceptible to IL-13 and IL-4 suppression, nor beta-2 adrenergic sensitivity. So recently, and we're coming to the end here, we developed a new thought. Cyclic AMP, you all learned in medical school, in your professional schools, is broken down by what? Phosphodiesterases, right? Phosphodiesterases break cyclic AMP down. And then when it's broken down to AMP and phosphate, it's inactive. We discovered a transporter. This transporter actually can leak cyclic AMP out of the cell more effectively than phosphodiesterases break it down. So here you can see giving formoterol or a beta or something that activates adenyl cyclase, we get intracellular cyclic AMP that goes up 800-fold in human airway smooth muscle cells. But look what happens. If I measured in the supernatant outside of the cell, it's the absolute reverse. It leaks out of the cell. So phosphodiesterases that you all learned about as breaking down cyclic AMP as everything was half right. Actually, the way you lose cyclic AMP is not through that, it's through the ABCC1 transporter. Here we're looking at extracellular cyclic AMP, and there's heterogeneity, which is exciting, Means not everyone behaves the same. And what we can see is the extracellular cyclic AMP is quite robust. So obviously you want to know, well, Panettieri, if you block that transporter, do you get more cyclic AMP? Yep. So if I use a pharmacologic inhibitor, I can double my dose of ISO-induced cyclic AMP, so I get a lot more cyclic AMP. And if I look at stiffness and relaxation, I can make this a super beta agonist by plugging the cyclic AMP transporter, which is really exciting to me. So this is good news. And we can see if we knock it out by using siRNA, we get the same effect. So the transporter, ABCC1, is the way you lose cyclic AMP in the cell. So this becomes really exciting to us as we try to understand the heterogeneity. Here again, we knock it down and we get much less extracellular cyclic AMP. And we can see that this occurs with the siRNA also, and it improves the intracellular cyclic AMP dramatically. Now, we didn't touch the phosphodiesterases. So I can overwhelm the phosphodiesterases in the cell by blocking this transporter and getting more bronchodilation. So then I told my postdoc, given this data, I want to measure cyclic AMP in the blood. He promptly told me, Dr. Panettieri, you know that that's an intracellular second messenger. It shouldn't be in the blood. I said, I know, but that's not what I asked you to do. I said, go check serum cyclic AMP levels. So we did this study with Jeff Chupp. We got a bunch of his well-characterized asthmatics. These are asthmatics, non-asthmatics. And we looked at serum cyclic AMP levels in the blood. And sure enough, the asthmatics had much more cyclic AMP in their blood in picomolar quantities than those of asthmatics. So what we have now is a new mechanism by which beta agonists can activate cyclic AMP. Yes, it's broken down by phosphodiesterases, and they're good bronchodilators, but much of the cyclic AMP leaks out through a transporter. And when we published this January in JCI using a very large cohort. This is a log phase here. You can see those patients with non-severe and severe asthma was dramatically different than non-asthma patients. So finishing up with one last story. This was a New England Journal of Medicine paper that we published using albuterol budesonide. And what we found is this combination, and for a number of reasons during my talk, you understand why this is important. Using this combination as rescue can decrease the number of exacerbations that asthmatics could have. So it's a much more effective rescue therapy. Now there's genomic and non-genomic effects of glucocorticoids. Some are acute, can happen within minutes, but most of you are familiar with steroid effects that are genomic. So we have a super sensitive assay where we can measure in real life, in real time, cyclic AMP generation. Here we got formoterol, and we get a robust increase using this tool. What we can then do is look at budesonide's effects with a beta agonist formoterol, could be albuterol. And what you get is a dramatic increase in the amount of cyclic AMP when you give steroids. You make a better beta agonist when you give these two at the same time, not genomically. We're not affecting gene expression at the same time. And it works for another bronchodilator, PG2, different receptor, same thing. When I give budesonide, marked improvement in signal. When I give budesonide alone, I get cyclic AMP. Well, that's weird. It's not a G protein coupled receptor. How's that happening? Well, we believe there's a plasma-lemma membrane receptor to which steroids binds and has enhancement. But that level of cyclic AMP doesn't bronchodilate. So in summary, we went through lots and lots of stuff. Biologics are important. Engage specialists. Most patients you see with asthma are not controlled. We want 0 exacerbations. We want to decrease oral corticosteroid burden. By using biologics, we have a 50% chance of making patients better. 50% still don't respond. Beta agonists and bronchodilators are really important. The muscle itself is intrinsically different than non-asthma, and context means a lot. If the patient has RV infection, rhinovirus infection, or has T2 inflammation, their bronchodilator response is not what it could be. We need other bronchodilators. Tachyphylaxis can occur with beta agonists. Giving steroids at the same time prevents that occurring. And we're optimistic. We're optimistic that we will develop new bronchodilators that aren't going to be plagued by the problems that we described today. And hopefully, blood cyclic AMP will be a new biomarker that predicts therapeutic response. I want to thank you all for this wonderful.
Great talk.
Good.
Yeah, I really want to congratulate Dr. Panettieri for a wonderful talk. And Dr. Kraft, question, please.
Great talk, Ray, as always. 2 questions for you. So can you comment on, because the smooth muscle, the airway smooth muscle is really intrinsically different, can you comment a little bit on the epigenetic aspect of that and maybe what exposures may influence that? And then the second question is, do biologics have any impact on those processes? You're talking about how steroids can really promote bronchodilation, we have effects on cyclic AMP. What about biologics?
That's a great question. So if I can remove the T2-ness by taking IL-13 and IL-4 away, I can restore the inhibition of that hypo-responsiveness. I don't intrinsically make the muscle that's more responsive in asthma like a non-asthma cell because there's no 13 and 4 there, right? But the context of 13 and 4 can be removed. And in our cell systems, and we're doing this work now, we could reverse the hypo-responsiveness with a biologic. So that, because the muscle has an IL-4 alpha receptor and the IL-13 R1 and R2 receptor, so we have all the requisite things. What's interesting is TSLP doesn't have the capabilities, because the TSLP receptor, R1, is not on airway smooth muscle. So I can give TSLP and not have any effect. IL-33 receptor, the ST1 receptor, is. And that does have this effect. So, you know, does TSLP have this phenomenon? I don't know. Coming back to your second question, where in the epigenetic phenomenon does this occur, or is it hereditary? I don't think it's hereditary. I think it's acquired. I think it's epigenetic. My sense would be this occurs very early in life, not later in life. And, you know, when we think about persistent airflow obstruction, AKA irreversible asthma, that likely is caused by poor development of the airways early in life that renders patients far less normal at age 30. When they get an inexorable loss in their lung function, they come to you at 40 with, now I can't breathe on the golf course, I can't walk 3 blocks without shortness of breath, and you find out, oh my gosh, their FEV1 is 62% predicted. And you attribute to that acute event something happened, like a viral infection. Now, they were like that probably at age 2. They didn't notice it until they start losing lung function. The problem is you can't regrow a lung. So the only thing you can do is prevent further exacerbations that could be impeding their lung function.
I got one, then we got you. So mine, if you don't mind. It's a prerogative. So you spent a lot of time up front describing how the current state of treatment for asthma just doesn't seem to work for most patients. And you discuss opportunities for it to get better with the approach you're talking about. But then you also showed that a lot of these current medications are downstream effectors, and then you showed that they're upstream drugs, right? For IL-4, IL-5. Yep. Why are we reserving the drugs that attack those upstream targets for only a small number of patients, given that the large number of patients aren't benefiting from our current strategy?
Yeah, well, I think A couple reasons. Pharma comes up with new drugs that are expensive. So they're going to position new drugs that are expensive with little side effects. You know, the beauty of biologics, everyone, is yes, they're very expensive, but they're incredibly safe. And so if you think of the 6 biologics we currently have in the asthma space, you can bathe in these and people don't really have complications from them. So they're safe, they make people a lot of money, and they do help some individuals, but only half of the individuals. So what we need to understand is the heterogeneity of asthma. There's no one size fits all. And that some people are going to be driven by some of these pathways, and others, like the low T2 people, I didn't even talk about here. And what is low T2? That is, in essence, no T2 signal. That's how we define it. What an awful definition. But that's a significant group. As many 15, 20% of patients have low T2, and we have nothing to treat these individuals with. So, you know, coming back to your point, Cap, I think we don't understand the heterogeneity of asthma. We know what will work. There is a possibility and a propensity to be, if you're T2, to respond to biologic, but not universally. If you don't have that T2 signature, you're not going to respond at all. We know that. So what we need are more therapies that hit multiple cascades.
Okay. Please.
Yeah, I have a question pertaining to the serum cyclic AMP levels. So like when you were comparing it in the asthmatic patients and the controls, were the patients with asthma receiving beta agonist bronchodilators?
Yes.
I think what I'm getting at is
It's confounding by disease, because these people are getting a drug that increases cyclic AMP. So is it not surprising you'd see it in their blood levels? Well, yes and no. This was sort of proof of concept that you could actually measure it, and it tracks. The other issue, to address your question, is it was unethical to give people that did not have asthma albuterol and then see if their cyclic AMP levels went up. But what we're going to do is we're segmenting and bucketing these individuals. If you saw, I went very quickly, there was a real heterogeneity in the amount of extracellular cyclic AMP in some of the donors. So think about that. If I'm not leaking cyclic AMP, it's having an effect in the cell to be more of a relaxant factor. So what we're now doing in a large study is comparing those people who have leaky cyclic AMP. They will not get the bronchodilator effect because it all leaves. They'll have worse FEV1 and unbridled inflammation. The cyclic AMP I measure in the blood is not probably coming from the muscle. It's a collective integrated signal from a bunch of cells. Guess what cyclic AMP and pKa activation does in immunocytes? It inhibits cytokine secretion. So our thought is if you have too much in your blood, it means you're not getting adequate anti-inflammatories and you're not getting a bronchodilator response. So we're going to be using this hopefully, and we've developed a point of care technique with a finger stick and measure cyclic AMP. Could actually be useful in primary care physicians' offices where we know no one is using spirometry, and they're rarely using asthma control tests. So what if I did a finger stick, like a hemoglobin 1AC, and I get a readout, and if you're a very high cyclic AMP person, that could predict therapeutic failure or potential exacerbation. So that's how we're going to use it. What I showed you is the tip of the iceberg of the stuff that we're doing now, but thanks for the question. Yes?
Just to go back to the other 50% of non-T2 patients, what are the, I guess, the drivers of that hyperinflammation in those patients?
Yeah.
And talk about the other immune cells, do you know?
Yeah, there's a lot of hypotheses, right? So the thought is low T2 is neutrophil driven. I don't know if that's correct. These people also get on oral steroids, the neutrophils, then demarginate, you get high neutrophils, and so it goes up. I don't know if that's really the case. We just don't have a handle. We do know the heterogeneity of the low T2 is worse than the heterogeneity of the high T2. Obesity is something that clearly can affect this. Environmental exposures. So if you think about ozone, sulfur dioxide, smoke, especially what you all experienced and we did from the Canadian wildfires, we saw a huge amount. That is not driven by traditional T2 signals. That's low T2 alarmin driven. And, you know, I think we're going to learn a whole lot more about that. It's just the heterogeneity of the low T2 group has impeded our ability to do real studies because I don't have a biomarker. You know, the lack of biomarkers is not a good definition, case definition.
I want to thank Dr. Panettieri. So great.
Thank you all.